Small bone injuries of the fingers, toes, hands, and feet are everyday presentations in the emergency department. Clinical examination alone can be misleading, and delays to radiography can slow decision making. Point of care ultrasound offers a rapid bedside assessment that can help confirm suspicion, localize the injury, and guide immediate management. It doesn't replace X-ray when imaging is required, but it can help target radiography, reduce unnecessary studies, and support faster, safer care. Plain radiographs remain the first-line test for suspected fractures, but they have real limitations in day-to-day practice. Small, non-displaced or occult fractures can be subtle or even appear normal on the initial films. Interpretation is also affected by overlapping anatomy and positioning, which can hide cortical disruption. In children, growth plates and unossified cartilage add another layer of complexity and can mimic injury. And beyond image quality, ED workflows such as transport, queuing, and reporting can delay decisions. This is where bedside POCUS can be a useful adjunct to support timely assessment. POCUS is particularly useful for small bone injuries because it lets you scan exactly where the patient is most tender and correlate findings in real time. It provides immediate bedside information, which is helpful when radiographs are delayed or when the initial film is equivocal. Ultrasound is also free of ionizing radiation and can be repeated for follow-up if symptoms persist. In children, where growth plates and incomplete ossification can complicate X-ray interpretation, POCUS can be a valuable adjunct. It does not replace radiography when imaging is required, but it can support faster, more targeted decision-making. For small bone fractures, start with a high-frequency linear probe to maximize near-field resolution. Select a musculoskeletal or superficial preset if your machine has one. Keep the depth shallow so the cortex fills a good portion of the screen, and place the focal zone directly at the cortical line. Then adjust overall gain, and if needed the TGC, until the cortex appears as a crisp, bright echogenic line with clean posterior shadowing. Once your image is optimized, keep the settings stable while you scan along the bone. On ultrasound, what we assess is the cortical surface. A normal cortex appears as a smooth, bright hyperechoic line with clean posterior acoustic shadowing. Your job is to confirm that this line is continuous. Start in long axis and sweep along the bone, then rotate into short axis to confirm the finding from a second plane. Keep the probe perpendicular to the cortex and adjust depth and focus so the cortical line is crisp, because obliquity can create false irregularity. On POCUS, the key fracture finding is disruption of the cortex. A normal cortex is a smooth, continuous bright line, so a fracture is suggested by a focal break, an irregularity, or a clear step-off. Sweep along the bone in long axis to find the point of maximal abnormality, then rotate into short axis to confirm it in a second plane. At the same site, look for soft tissue clues such as periosteal elevation or a localized hematoma. You may also notice abnormal artifact at the defect, which can support the diagnosis when the cortical break is subtle. Take a moment to review this ultrasound image. What do you think you are seeing? Would you call this a fracture or not, and why? This image may look like a cortical step-off, but this is a common pitfall. Normal anatomy, especially near a joint, can create an apparent break in the bright cortical line. In addition, if the probe is even slightly oblique, the cortex can lose brightness and appear interrupted, which can falsely suggest a fracture. The fix is simple. Rock the probe to keep it perpendicular, then sweep a little proximal and distal to locate the joint line and confirm continuity. Always confirm any suspected defect in two planes, correlate with point tenderness, and compare with the contralateral side if you are uncertain. Start where the patient is most tender, because that is often where the cortical abnormality will be most obvious. Align the linear probe in long axis and sweep slowly along the bone, keeping the probe perpendicular to the cortex to avoid false irregularity. If you see a suspected break or step off, pause, optimize the image, then rotate into short axis to confirm the defect in a second plane. Finally, document the best cine loop and a still image of the finding, ideally centered on the defect for clear review and reporting. For very superficial targets like fingers and toes, image quality often fails in the near field. Use a generous gel standoff or a water bath technique for digits to improve coupling and reduce probe pressure. Keep a light touch because excessive pressure increases pain and can distort the tissues you are assessing. Set a shallow depth, place the focal zone at the cortex, and fine-tune gain to make the cortical line crisp. Finally, before calling a scan normal, recheck that the probe is perpendicular to the cortex and repeat the sweep in 2 planes. Think of POCUS as an adjunct within your usual fracture pathway. Start with clinical assessment, including a neurovascular check, and apply decision rules where they fit. For accessible small bones, POCUS can be used early to target the painful area and support rapid bedside decisions. If POCUS is positive, immobilize and treat pain, then obtain radiographs when you need fracture classification, alignment assessment, or management planning. If POCUS is negative and clinical suspicion is low, manage conservatively with clear return precautions and follow-up. If the scan is equivocal or suspicion remains high, proceed to radiographs and consider further imaging when appropriate. POCUS is a helpful adjunct, but it does not replace clinical judgment or radiographs when imaging is indicated. The common pitfalls are artifact from an oblique probe angle, misinterpreting a joint line, and normal variance, especially near physes in children or around accessory ossicles. If you suspect intra-articular extension, displacement, or malalignment, or if clinical suspicion remains high despite a negative or equivocal scan, escalate to X-ray. The key takeaway is simple. Focus on cortical continuity, confirm findings in 2 planes, and always correlate with focal point tenderness, using the contralateral side for comparison if you are uncertain. For the hand, the small bones we scan most often are the phalanges and metacarpals, with the carpal bones proximally at the wrist. Use the dorsal or palmar approach depending on where the patient is most tender and where you can place the probe comfortably. In practice, the dorsal surface is often easier for cortical assessment because there is less soft tissue, but if the pain is clearly palmar, scan that side as well. On the clinical photo, palpation of the anatomic snuff box reproduces the patient's pain, raising suspicion for a scaphoid injury. On ultrasound, there is a focal interruption of the bright cortical line, consistent with a fracture. On the radiograph, there is a subtle lucency within the scaphoid, which can be easy to miss on early films. Finally, the anatomy diagram highlights the carpal layout and helps you target the scaphoid accurately during the scan. For the foot, the bones we most often scan are the phalanges and metatarsals, with the tarsal bones proximally in the midfoot. Choose your probe position based on where the patient is most tender. In practice, the dorsal surface is often easier for cortical assessment because there is less soft tissue, but if pain is clearly plantar, including under the metatarsal heads or sesamoids, scan the plantar side as well.